Discussion on carbon dioxide angiography. Arteriogram using carbon dioxide injection. Usual angiograms appear dark, while this is grey because of the lower density of carbon dioxide compared to tissue. Conventional angiogram is shown beside the carbon dioxide angiogram for comparison of opacification. Please note that the angiograms are not in the same projection. Carbon dioxide angiography is resorted to in cases of renal failure. Iodinated contrast has the risk of contrast-induced acute kidney injury, more so in those with pre-existing renal insufficiency. Earlier, those with renal issues were considered for magnetic resonance angiography, which is also called dye-less angiography, as blood vessels can be visualized with contrast obtained from moving hydrogen nuclei in water, an important constituent of blood. For better visualization, gadolinium-based contrasts are often used in magnetic resonance angiography. Gadolinium-based contrasts have been associated with nephrogenic systemic sclerosis in those with renal failure. Hence, the role of carbon dioxide angiography in those with renal failure, as carbon dioxide is devoid of any such toxicity. As CO2 is highly soluble in blood and rapidly cleared from circulation, it is ideally suited as a negative contrast agent in those with renal failure. Technique of CO2 angiography is a little more cumbersome than contrast angiography. We need medical grade carbon dioxide cylinder, 3-way stopcocks, connected tubings, syringes, and a reservoir bag for interim storage of carbon dioxide. Initially, the reservoir bag is connected to the CO2 cylinder and CO2 drawn into it multiple times to flush out room air present in it. After that, the bag can be connected to the angiographic manifold attached to the proximal end of the catheter for CO2 injection. High flow rates can cause mesenteric ischemia due to vapor lock, which can be managed by rotating the patient side to side and gently massaging the abdomen. Carbon dioxide angiography is an alternative in those with contrast allergy, as carbon dioxide is non-allergenic. Carbon dioxide angiography should not be used for cerebral vessels, and injections should be below the level of the diaphragm. That would mean that it cannot be used in the thoracic aorta or for coronary angiography. Many of the complications of carbon dioxide angiography are at least partly contributed to by contamination with room air. Occasional reports of fatality following carbon dioxide angiography prompted a study on the safety. A retrospective study of 951 patients who underwent 1007 carbon dioxide digital subtraction angiography procedures over a 21-year period has been reported. 632 were arterial procedures, which included 527 aortograms, 100 extremity arteriograms, and 5 pulmonary arteriograms, 187 inferior vena cavograms, 182 hepatic or visceral venograms, 5 extremity venograms, and 1 superior vena cavogram were the venous procedures. Associated endovascular procedures were done in 499 cases. Of the 4 deaths in the series, 1 was due to suppurative pancreatitis following aortogram, and another with hepatic bleed following failed transjugular intrahepatic portosystemic shunt. Another was due to metastatic carcinoma, and 1 due to refractory end-stage cardiomyopathy. A randomized study has been conducted on quality and safety of automated carbon dioxide DSA in femoropopliteal lesions. All the 50 patients in the study underwent both iodinated contrast media and carbon dioxide angiography for the same target lesion. Inter-rater agreement was fair to excellent for overall image quality. It was fair to excellent for visibility of collaterals and poor to excellent for assessment of stenosis or occlusions. Adverse events noted were hematoma in 2 patients, pain related to puncture in 1, and nausea and vomiting in another. Some of the indications for carbon dioxide angiography are 1. Abdominal aortography, 2. Renal transplant arteriography, 3. Visualization of portal vein with wedged hepatic venous injection, 4 for guiding endovascular procedures.